Sure. So the field of using an anti-CD40 ligand as a potential way to modulate the immune system has been going on for a number of decades. It took a most recent evolution because of technology advancements in how we develop antibodies about a decade ago. We started working on what is today Tegoprubart uh, about 7, 8 years ago. And that initial work was done at a nonprofit called the ALS Therapy Development Institute. That's where Tegoprubart was initially invented. And Eledon was created in the fall of 2020 using and based on the work that had been done at the ALS Therapy Development Institute. So the anti-CD40 ligand mechanism plays a central role in how immune cells talk to one another. At the core, it impacts how T cells interact with other cell types, in particular antigen-presenting cells and B cells. So if we look at how an immune response is mounted, typically an antigen-presenting cell will present an antigen. So that could be a sugar or protein to the T cells. The T cells are, in a certain way, the police officers of the immune system. And that T cell will then decide if the antigen that it's shown is self, in which case it will tell the immune system to calm down, or foreign, in which case it will turn on or activate the immune system. If the T cells decide to activate, they can become one of two types of cells. They're called helper and killer T cells. The killer T cells do exactly what it sounds like. They attack cells directly, and the helper T cells have that name because they in turn activate B cells. And the B cells are the cells that are producing the antibodies, or as I'd like to think of them, the arrows of the immune system. If the T cells do not activate, but look at the antigen and decide that it's self, in order to calm down the immune system, they turn on the brake of the immune system, which they do by becoming a type of a cell called a T regulatory cell. What Tegoprubart, our antibody, does is by interfering with how T cells communicate with both B cells and antigen-presenting cells, it decreases the ability of the T cells to become either killer or helper T cells, otherwise known as CD4, CD8 positive cells, and it increases instead the T cells polarizing or activating themselves into becoming the brakes of the immune system, the T regulatory cells. So in other words, this is a very targeted and novel approach to immunotherapy, which both takes the foot off the proverbial gas pedal of the immune system by decreasing the number of killer and helper T cells, and it puts the foot on the brake pedal, if you will, of the immune system by increasing the number of T regulatory cells. Now, importantly, this is different from how traditional immunosuppressants have worked. Traditionally, they've worked by wiping out populations of white blood cells. Tegoprubart does not do that. It doesn't wipe out populations of white blood cells. They remain there in case they may need to be activated. The difference is, while they continue to exist, they behave in a different manner because of the drug. So the potential benefits of Tegoprubart are multiple-fold. What we are looking to do is to have a novel immunosuppressant, particularly for transplant medicine, that is both more effective as well as safer than the alternatives that are available today. In transplant medicine today, the primary or the cornerstone immunosuppressants that's used is a class of a drug called a calcineurin inhibitor. Calcineurin inhibitors have made modern transplant medicine possible. They've been around for over 30 years, but there's been little innovation in the field since their launch in the mid-1990s. What we are looking to solve is twofold. If we look at the most common type of transplantation, which is kidney transplant, the average kidney transplant only lasts about 10 or 12 to 15 years after transplantation. And the reason for that is the following, and it comes down to, in large part, the type of a drug that we're using to protect the organ from immune system attack, so the calcineurin inhibitors. The calcineurin inhibitors, ironically, are both directly nephrotoxic, so directly toxic to the kidneys, as well as indirectly nephrotoxic. And I say that because they cause both hypertension as well as hyperglycemia, or what's called post-transplant new onset diabetes, the latter because they are directly toxic to the beta cells of the pancreas that manufacture insulin. And of course, this is a further irony, since the two most common reasons why people need kidney transplants to begin with are hypertension and diabetes. So what we are looking to develop is a drug that will be better at protecting the immune system, as well as one that will not have the direct and indirect effects of the CNIs, so of the calcineurin inhibitors. And indeed, to date, that is what we've begun to see in both our animal work as well as our human work. Sure. So we've generated data to date in transplantation in 3 areas: kidney transplantation, islet cell transplantation, as well as in xenotransplantation. In kidney transplantation, we reported out data at the American Transplant Congress last June, and there we presented data on our first 11 subjects, with 2 subjects that had completed a year. That data primarily looked at safety and tolerability, but also looked at eGFR over time. The reason why the eGFR is important is that in our discussions with the FDA, we agreed that eGFR would be our primary endpoint for the ongoing phase 2 study. In June, when we reported the data from a safety and tolerability perspective, we showed that the drug was generally safe and well tolerated. But what truly stood out was that we did not see the traditional side effects that are seen with calcineurin inhibitors. So we didn't see an increase in hypertension, as an example. We didn't see an increase in high blood sugars, hyperglycemia, or new onset diabetes. And we also did not see the CNS effects that are often seen with CNIs, such as tremors or brain fog. From an efficacy perspective, looking at eGFR, we did see average eGFRs that were much higher than what has historically been reported as typically seen post-transplants using calcineurin inhibitors. So in the past, typically after a kidney transplant, eGFRs range in the 50 to 55 range. And in our study, the eGFRs were in the high 60s to 70 range. Aside from kidney transplantation, in November, we reported out data in our islet cell transplant study. And there we reported data on the first 3 subjects. And what stood out with that data was, again, that the drug was it was generally safe and well tolerated, but also that in two of the three patients, and the third patient had only been in the study for a few weeks, so wasn't out long enough. But in the first two patients that had been out long enough, they were able to get an islet cell transplantation and get fully off insulin, despite the fact that beforehand they had had very hard to control or near uncontrollable type 1 diabetes. So it was remarkable that these individuals who beforehand had experienced severe recurrent hypoglycemic events, as well as having overall generally high blood sugars, went from that almost uncontrollable profile to being fully off insulin. When it comes to xenotransplantation, we've now completed 3 pig-to-human xenotransplantations, and we continue to learn a lot from this field as it progresses. And the last patient that we transplanted was just a few weeks ago. We reported out on that patient last week. So we look forward to being able to provide updates and for hopefully that gentleman to continue to do very well. Of note, since we're talking to nephrologists, it was striking in this last gentleman who had a pig xenotransplant that pretty quickly that gentleman's creatinine went to a 1, so became normal. So this is an individual who was on dialysis. It did not look like he had good prospects for getting a human kidney. He got a porcine kidney and is now doing quite well. So overall, that is the data that we've generated to date in transplantation, and we look forwards to reporting out data across our studies later this year.